Welcome, and thank you for joining us for this presentation, Therapeutic Advances for the Patient-Centered Management of Hypercholesterolemia. This activity is based on a satellite symposium from the 2017 Patient-Centered Medical Home Congress. This activity is supported by an educational grant from Amgen and is jointly provided by North American Center for Continuing Medical Education and the National Committee for Quality Assurance. I'm Ty Gluckman. I serve as Medical Director for Clinical Transformation at the Providence Heart and Vascular Institute in Portland, Oregon. As you can see here, I have disclosed no relevant financial relationships with any commercial interests. We're going to be discussing a number of things in today's presentation, and the learning objectives are listed here. Specifically, we're going to outline the latest clinical guidelines surrounding the treat-to-target approach to hypercholesterolemia management. We're next going to be evaluating the mechanism of action, efficacy, safety, and indication of PCSK9 inhibitors to identify appropriate patient candidates. We're going to integrate the latest clinical data and guideline recommendations into individualized management plans for high-risk hypercholesterolemia patients that promote adherence and align with NCQA patient-centered medical home standards. And finally, we're going to implement value-based care models such as the PCMH to improve the quality and coordination of multidisciplinary, team-based hypercholesterolemia care. As you can see here, hypercholesterolemia is an important factor in increasing one's risk for a first myocardial infarction. This is data displayed from the InterHeart study, a large study of approximately 30,000 individuals from 52 countries. And this study sought to ask the question of the factors that potentiated or increased the risk for a first myocardial infarction. These were patients initially without established atherosclerotic cardiovascular disease, and as you can see in green, a number of the different lifestyle factors or risk factors that increase the risk for a first myocardial infarction. To the far right, you can see in yellow that all of these risk factors added together account for about 90% of the population attributable risk, but lipid abnormalities account for approximately 50% of the population attributable risk for a first myocardial infarction, underscoring the importance of treating hypercholesterolemia in at-risk individuals. This next slide is quite an interesting one and relates to a study that was done and published back in 2004 that looks at different populations, including hunter-gatherer humans, wild primates, wild mammals, and the modern human, and in this case is looking at total cholesterol, but highlights the fact that the modern adult American has a total cholesterol level that is almost twice in excess or greater for what we see in related mammals, primates, and in particular other hunter-gatherer humans. They're really divorced from and separated from westernized lifestyle that may be enriched with risk factors that increase the risk for cardiovascular events. And this is one of my favorite slides. This is the cover of The Economist from 2004, but I would argue that it is as real today as it was back 13 years ago, highlighting the fact that we have actually devolved as opposed to evolved by enriching ourselves with risk factors that increase the risk for cardiovascular disease, which continues to represent the #1 cause for men and women alike in the United States and worldwide. This next slide is an important slide, and I would be remiss if I didn't highlight the fact that all pharmacotherapy that we would prescribe, recommend to individuals either at risk for or with established atherosclerotic cardiovascular disease is on a bedrock of appropriate lifestyle intervention. And this is pooled data from a number of different studies highlighting the fact that if you restrict saturated fat and cholesterol intake, enrich your diet with plant stanols and sterols, increase the consumption of dietary fiber, soy protein, tree nuts, including almonds and walnuts, and reduce your weight, in total, you can achieve upwards of a 30 to 45% reduction in LDL cholesterol. The challenge, as I think many of you know, is it's hard sometimes for individuals to do one of these, let alone each of these, and thus there is an unmet need to further lower LDL cholesterol in these at-risk patient populations. As you can see here, in 2013, the American College of Cardiology and the American Heart Association came out with their updated blood cholesterol guidelines. And they take you through an algorithm to determine who is appropriate for lipid-lowering therapy, and in particular statin therapy, and they highlight the appropriate intensity in different patient populations. So it takes you through an algorithm with questions that you should be asking yourself when you're faced with evaluating a patient. First and more, these were adult cholesterol guidelines, and thus they restricted really the algorithm to those greater than 21 years of age. And I would encourage you to look at other resources to be able to determine appropriate treatment algorithms for those younger than 21 years of age. But if you're greater than 21 years of age and you're a candidate for statin therapy, the first question that should be asked is, do you have clinical atherosclerotic cardiovascular disease? Have you had a heart attack? Have you had a stroke? Have you had bypass surgery, angioplasty? Do you have symptomatic peripheral arterial disease? And if the answer to that question is yes, it asks the question that based on age less than or equal to 75 years, really the recommendations highlight that you should be on a high-intensity statin, reserving moderate-intensity statin therapy for those that may not be a candidate for the higher intensity. And if you're greater than 75 years of age or not a candidate for high-intensity statin therapy, then a moderate-intensity statin would be appropriate. If the answer is no, you don't have clinical atherosclerotic cardiovascular disease, the next question is, do you have an LDL cholesterol greater than or equal to 190 milligrams per deciliter, which based on the guidelines defines the phenotype of a patient who has familial hypercholesterolemia. And if in fact you fit in this category, you should be recommended high-intensity statin therapy. If the answer is no, you don't have clinical atherosclerotic cardiovascular disease, and you don't have an LDL cholesterol greater than or equal to 190, then the question is, do you have diabetes, and are you between the ages of 40 to 75 years? And if the answer is yes, the recommendation is for all individuals at a minimum to recommend moderate intensity statin therapy, but really before recommending that statin, you should be calculating their 10-year risk of atherosclerotic cardiovascular disease, namely what is their risk of a fatal or non-fatal heart attack or stroke. And if that risk is greater than or equal to 7.5%, a high-intensity statin therapy is recommended. If it's less than 7.5%, then a moderate intensity statin therapy is recommended. And this last bullet highlights the fact that the preponderance of data guiding our recommendations around statin use in diabetics comes from those who are between the ages of 40 to 75 years. To be clear, it doesn't mean that your risk is appreciably lower at individuals less than 40 years of age, and your risk certainly doesn't go down if you exceed 75 years of age. And so guidance should be driven based upon weighing the risks and benefits of statin therapy in these other at-risk patient populations who have diabetes, who are below the age of 40 years or greater than 75 years of age. As you can see here, atherosclerotic cardiovascular disease is a highly prevalent condition. This is data taken from the 2017 Heart and Stroke Disease Statistics and highlights the fact that there are in excess of 15 million individuals in the United States with coronary heart disease. There are approximately 12 million individuals with established cerebrovascular disease, either with a prior TIA or stroke, and there are upwards of 9 million individuals with peripheral arterial disease. Now, this data can't be taken as adding one bar graph on top of another, because some of these populations may in fact have coronary heart disease, cerebrovascular disease, and peripheral arterial disease, but nonetheless underscores the fact that there are millions of Americans with atherosclerotic cardiovascular disease in whom intensive statin therapy is recommended to reduce their cardiovascular risk.
So what about familial hypercholesterolemia? Some of you may be saying, I've heard vaguely about that, or when I went through training, I learned about Mendelian genetics, and it was this rare bird of learning about autosomal dominance and trying to understand what that meant. And yes, it's true that homozygous familial hypercholesterolemia classically was taught, at least to me, as a prevalence of 1 out of a million, meaning there are about 315 people in the United States with this condition. It turns out that the prevalence is about 3 times greater, but heterozygous familial hypercholesterolemia, 1 copy from your mom or 1 copy from your dad, has a prevalence of about 1 out of every 200 to 250 people. And so We look in this room, there may be one person with familial hypercholesterolemia. We have a patient panel of 2,000 patients. You may have 10 people with familial hypercholesterolemia. And we talk about it as a rare bird, but when you look at other, let's say, less frequent conditions, familial hypercholesterolemia is 4 times more prevalent than sickle cell disease, 5 times more prevalent than cystic fibrosis, and the presence of familial hypercholesterolemia is associated with a 20 times greater risk of having atherosclerotic cardiovascular disease. I would be remiss if I didn't share this information. The vast majority of people out there don't have diabetes, they don't have familial hypercholesterolemia, and they don't have clinical atherosclerotic cardiovascular disease. But the guidelines did call out that for those people that don't fit in that category, you should be calculating their 10-year and also lifetime, which we often use as 30-year duration, their risks. And if they are at a higher risk group, those individuals may well benefit from statin therapy in spite of not having diabetes, familial hypercholesterolemia, or atherosclerotic cardiovascular disease. And a recent trial published in the last 2 years showed that in an intermediate risk group with no established atherosclerotic cardiovascular disease, moderate intensity statin therapy reduced the risk of fatal and non-fatal cardiovascular events by about 25%. So let's focus in about lipid-lowering therapy in atherosclerotic cardiovascular disease. And if you're going to take one thing, I hope you take more than one thing away from this. The answers of 1 through 10 is statins, 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 statins. And I'm going to come back to that because it's an easy thing to say, and operationalizing this is sometimes a challenge. This is a pooled analysis of multiple randomized clinical trials, either placebo-controlled or active intervention versus a different active intervention. And the relationship here, even though this is a busy slide, is as we pharmacologically with statin therapy in secondary prevention of people with atherosclerotic cardiovascular disease, as we lower their LDL cholesterol, your risk for adverse cardiovascular events goes down. You are at reduced risk of having bad things happen by lowering your LDL cholesterol. So how are we doing in those at highest risk? This is an analysis of the world's, I want to underscore this, the world's largest ambulatory registry tracking performance of key quality measures, largely enrolled by cardiologists. I am one. This is embarrassing to me. Look at the group that's in the box. This is 1 million patients with established atherosclerotic cardiovascular disease, asking the question contemporarily in the United States, how are these people being managed? In dark red, 27.9% of those people are receiving 0 lipid-lowering therapy, 3% are receiving a non-statin. A full 30% excess of people in the United States with clinical atherosclerotic cardiovascular disease managed by a cardiologist ain't receiving a statin. This is even talking about the intensity of statin. They're receiving no statin at all. This is beyond embarrassing, and it's a call to action. It's something that I'm passionate about in different forums, about saying how do we close these gaps in care. Again, if you have atherosclerotic cardiovascular disease, you ideally should be on high-intensity statin therapy, and if you can't tolerate it or you're over the age of 75, an option is moderate-intensity statin therapy, not no intensity of statin therapy. So what are the intensities of statin therapy? The authors of the cholesterol guidelines divided them into 3 groups based on the average effectiveness with which the statin lowered their LDL cholesterol. So high-intensity statin therapy is defined as a 50% or greater average reduction in LDL cholesterol. Now that's average. There may be some people who only get a 20% reduction with one of these 2 agents at these 2 doses, and somebody may get an 85% in their LDL cholesterol. Moderate intensity statin therapy is defined as an LDL cholesterol reduction of 30 to 49% on average, and low intensity, which is not recommended for most individuals de novo, is a less than 30% on average reduction in LDL cholesterol. What is the data supporting the benefit of high-intensity statin therapy? This is a meta-analysis of nearly 40,000 individuals who were randomized in clinical trials to more intensive versus less intensive statin therapy regimens, and a more intensive statin therapy regimen was associated with a highly statistically significant 15% reduction in the rate of fatal and non-fatal cardiovascular events. So the higher intensity of therapy is associated with greater reduction in adverse events. So how are we doing in those at highest risk? This is a cohort study from the VA health system. And I am a huge fan of the VA health system. I don't currently work in one. For the last 12 years I haven't, but I did in years past. They do a lot of great things about care coordination. But look at this. These are patients with clinical atherosclerotic cardiovascular disease, almost 1 million of them. What were the percent of people, each bar represents a different facility, what was the percent of individuals receiving high-intensity statin therapy in those facilities? The top performer was 35% of the time. The bottom performer was at below 10% of the time. In spite of the fact that we have guidelines and data through multiple randomized trials enrolling in excess of over 100,000 people in these trials, we are not translating that into clinical practice today. And it begs the question, well, what we should be doing, but should we even be pushing LDL cholesterol levels lower? So this is a pooled analysis, a meta-analysis of almost 40,000 individuals. And this is hypothesis generating. This is not definitive. Both the left and the right sides are just different graphical ways of showing the same thing, that the point estimate, or the rectangle, followed by the confidence intervals, the lines on either side, as we achieve lower and lower LDL cholesterols pharmacologically in these trials, people who get to lower levels do better overall. Now, this is hypothesis generating, this isn't definitive, but I'm going to show you some data that's very inviting of this going forward. So what about non-statin therapy and the 2017 update to a 2016 pathway document published by the American College of Cardiology identified the 4 statin groups: primary prevention, diabetics, familial hypercholesterolemia, and clinical atherosclerotic cardiovascular disease, and took them through a whole process of what should be done initially to reinforce adherence and lifestyle, how to address statin intolerance, controlling other risk factors, etc., and then reviewed a number of different pharmacologic therapies that could be considered for those individuals. They also brought back, this seems like Groundhog's Day, they brought back an optional secondary goal. So the principal goal, if you today have familial hypercholesterolemia or atherosclerotic cardiovascular disease, the goal should be getting a 50% reduction in LDL cholesterol as goal number 1. But they did list a second goal that you can consider getting your LDL less than 70. Now, to be clear, if I start with an LDL of 100 and my LDL drops to 65, I haven't achieved goal number 1, which is a 50% reduction in LDL cholesterol. So this is only a secondary target once you have already achieved a 50% reduction in your LDL cholesterol. What is the data to support some of the pharmacologic therapy recommended in this document? This is the Improve It study. It was a study of over 18,000 individuals with a recent acute coronary syndrome, unstable angina, ST segment elevation myocardial infarction, non-ST segment elevation myocardial infarction. And at the time this trial was designed, it was prior to the most recent guidelines, and they randomized these people to moderate intensity statin therapy versus moderate intensity statin therapy plus ezetimibe, asking the question of what was the incremental gain from a non-statin being ezetimibe. It was associated with a 20% reduction in LDL cholesterol and a small but statistically significant 7% relative risk reduction in the rate of adverse cardiovascular events. I'm now going to pivot and talk about a new class of non-statin medications, the newest on the block, but it's been around now for almost 2.5 years, and they are the drug class referred to as PCSK9 inhibitors. And I want to share this story because I think it's a really engaging story. I'm going to do this a little out of the actual chronologic sequence with which things occurred, but the protein called PCSK9 was discovered in 2003, not that long ago. And going from discovery of a protein to drug development in just over 10 years is mind-blowing. This is the ERIC database, and some of you may be familiar with the ERIC database. It's Framingham-ish like, where generous individuals in 4 geographically disparate communities are willing to swab their cheek and submit genetic material. They have regular blood draws. They have vital signs checked. Their medications are reviewed, and they fill out a ton of surveys. And they are just good, generous souls who, for medical knowledge, contribute a lot of information to advance knowledge. And in the top panel, this is the distribution, in this case, of LDL cholesterol in an all-comer ERIC database. And it's a bell-shaped distribution. There are some people out there with high levels, there are some people out there with low levels, and most people are the Goldilocks somewhere in between with middle levels overall. They identified a group of individuals, and this was more prevalent in African American individuals, but it was still prevalent in Caucasian individuals, where all of a sudden in the bottom panel on the left, their LDL cholesterol, lo and behold, was shifted to the left. These people, for some reason, had lower LDL cholesterol levels. And on the right-hand side, the people who had these lower LDL cholesterol levels had a dramatic reduction in the percentage of individuals that went on to have a symptomatic coronary heart disease event. And these people were born with a good genetic mutation where they had what's called a loss-of-function mutation in something called PCSK9. Their PCSK9 didn't work as well, and they reaped the benefit of an inborn error in their DNA in being able to have, on average, lower LDL cholesterol levels. So what does PCSK9 do? It's actually present in multiple cells in the body, but let's look at the liver cell, your hepatocyte. And in the liver, a PCSK9, which is on the right-hand side and is this orangish boomerang shape, gets secreted by the cell into the bloodstream. And it forms a triad with circulating LDL cholesterol that binds to the LDL cholesterol receptor. When PCSK9 binds to it, it internalizes that triad and everything gets destroyed. However, in people who have a loss-of-function mutation, that boomerang can't do its job. The LDL cholesterol receptor and LDL cholesterol form a dyad. That gets internalized. The LDL cholesterol itself gets destroyed and the receptor gets recirculated to the surface. If many of you hearken back to a day, if you have more receptors on your liver to remove LDL cholesterol, your level in the bloodstream goes down, and presumably your risk goes down. So people far smarter than me said, can I replicate someone's genetic mutation? And so they developed a monoclonal antibody that would be injected either every 2 weeks or once a month to simulate the person who has a loss-of-function mutation in PCSK9. They're not producing a genetic mutation, but they are producing the effects that a genetic mutation would have. And lo and behold, more LDL cholesterol gets destroyed, more receptors get recirculated to the surface to clear more LDL cholesterol, the levels in the bloodstream go down. This is one of the two FDA-approved agents, alirocumab, and what you can see are three distinct curves that are listed here. The first is, if I give alirocumab shown in blue, the levels of alirocumab in the bloodstream will rise very quickly. In gray is free circulating PCSK9. It gets bound by the antibody immediately, levels plummet. And what happens to LDL cholesterol? Just look, if you will, on the right-hand side of this and look at the red decrement. You achieve upwards of a 60% reduction LDL cholesterol very promptly after being administered a PCSK9 inhibitor. So I'm going to cut to the chase of what really were 3 to 5 years of a whole bunch of trials that were looking at surrogate endpoints for measuring the effectiveness and safety of PCSK9 inhibitors. This was the trial that dominated all of the lay press and medical literature news in March of 2017 when it was presented at the American College of Cardiology meeting and concurrently published in New England Journal of Medicine. And when the TIMI group presented this was the Fourier trial that took 27,000 plus individuals, all with stable atherosclerotic cardiovascular disease, all on moderate or high-intensity statin therapy, all with an LDL cholesterol greater than or equal to 70. Because if you'll recall, it was still debated whether if you're less than 70, do you even need more therapy? These people would be argued to need more therapy, and they randomized them to evolocumab, one of the other PCSK9 inhibitors, versus placebo, asking the question, what was the impact on adverse cardiovascular events? Injection with evolocumab either every 2 weeks or once a month resulted in a 60% reduction in LDL cholesterol, a 2% absolute risk reduction, and a 15% relative risk reduction in this quintuple primary endpoint. In cardiovascular medicine, we often like to refer to something called the triple endpoint, which is cardiovascular death, non-fatal MI, and non-fatal stroke. And in fact, that was the key secondary endpoint. There was a similar 2% absolute risk reduction, a 20% relative risk reduction that was associated with a reduction in these events. Importantly, there wasn't a mortality benefit, but this was driven by a reduction in non-fatal events. This is an interesting type of analysis. Some of you may be familiar with, some of you may be unfamiliar with. It's called a landmark analysis. And essentially what this does is it allows us to determine for a trial that runs a certain period of time, what is the magnitude of the intervention early versus later. And you can set your time when you make this decision at any point. So on the leftward side, this is that key triple endpoint. And what you do is you look during the first year and how those curves separate. There's a 16% relative risk reduction, statistically significant in the first 12 months of therapy. And then you wipe the slate clean. You start the clock over again. You say at day 366, first day of the new year, what were the rates of events that accrued from 1 year on? And in fact, there's a 25% relative risk reduction. If you look at just the non-fatal events here, fatal or non-fatal MI or stroke, I apologize, fatal or non-fatal MI or stroke, there's a 19% relative risk reduction the first year and a 33% relative risk reduction beyond the first year. The impression being that these curves separate early and continue to separate out over time. This is another one of those slides that I want you to take away from. Remember when we were all born, our LDL cholesterol was around 30 to 35. That's probably where we were genetically programmed to be, absent having a form of familial hypercholesterolemia. In red are the 4 quartiles of LDL cholesterol achieved by people randomized to evolocumab in this trial. Blue is placebo. The mean LDL cholesterol level achieved in this trial was 30 milligrams per deciliter, the lowest achieved level we've ever had in a randomized clinical trial of any drug ever. What about the safety of these interventions? This is the rate shown in blue for evolocumab, red is placebo. There was no appreciable difference in any of the endpoints other than a 0.5% absolute increased risk of injection site reactions, which is mild erythema, at the site in which you received the injection overall. Extraordinarily well tolerated, and people had speculated as to whether or not there may be any relationship with neurocognitive effects. A separate trial not presented here called the Ebbinghaus trial, published around that same time, enrolled 1,500 patients as a subgroup from this, did formal neuropsychiatric testing, neurocognitive testing, no difference in events, the frequency with adverse events between the 2 arms of the trial. A question that some of you may be asking is there such a thing as too low? Is there a floor below which we should not be dropping LDL cholesterol? And as you can see here, depending upon how you bring your LDL cholesterol down, there is the suggestion that lower and lower and lower is in fact better. And if you really want to have your mind blown, look at this. This was just presented at the European Society of Cardiology now about 6 to 8 weeks ago in Barcelona. This looked at people who got their LDL less than 10. 500 people in the evolocumab arm had an LDL cholesterol less than 10, shown in pink, compared to, in red, people who had an LDL of 100 milligrams per deciliter. They had the greatest absolute reduction in the rate of adverse events and not one signal of safety or harm. Now, there are people in this audience who are probably saying, wait a minute, I know that my cells need cholesterol. Yes, but your bloodstream does not. Your plasma does not. And so we do need cholesterol in our body, but arguably we don't need cholesterol at all in our bloodstream overall, which has an atherogenic effect overall. I'll cut to the chase of this is I had a patient just in the last week, 63-year-old man, first heart attack, LDL cholesterol naive to therapy, 68 milligrams per deciliter. Started on high-intensity statin. His LDL 2 months later is 7. I'm not adjusting his therapy. He's on a high-intensity statin. He got there with statin monotherapy, doesn't need a non-statin added overall, but we're getting to supraphysiologic reduction in LDL cholesterol, unlike we've ever seen before. And so we don't see people pulling back. There is no argument to pull back. And then really the question is, when you get beyond statin therapy, where are the roles for these other non-statin agents, which we'll get to? I do want to mention that we're anticipating, fingers crossed, that in March of 2018, the other PCSK9 inhibitor, alirocumab, is having its definitive cardiovascular outcomes trial called Odyssey Outcomes. 18,000 rough patients with a recent acute coronary syndrome randomized on a background of high-intensity statin therapy to alirocumab versus placebo, looking at hard cardiovascular events with an anticipated duration that may be out to a period as long, or a mean of between 3 and 4 years. So really changing the landscape, not just about PCSK9 inhibitors, but our understanding of lipid biology. And we used to call it the LDL-cholesterol hypothesis. I'd submit it's no longer a hypothesis. This is proven. Getting lower is in fact better. So a question that was asked at the beginning, a little teaser for the question that's going to be asked at the end, is the ACC expert consensus on non-statin therapy for atherosclerotic cardiovascular disease. Left side without comorbidity, right side in the question that we asked with comorbidity. I'm going to blow up what the options were. If you have no comorbidity, the recommendation is to start considering ezetimibe first, followed by the addition of a PCSK9 inhibitor. If you have a comorbidity, like diabetes, like chronic kidney disease, like recurrent adverse events, then in those individuals, the recommendation is to choose either ezetimibe or a PCSK9 inhibitor as your first second-line agent to be added on to a person on maximally tolerated statin therapy. So let's change directions with familial hypercholesterolemia. Again, not as rare of a bird as we thought. This is the spectrum, and for those of you who have not seen it, those people who have homozygous familial hypercholesterolemia can have LDL cholesterols in excess of 500 milligrams per deciliter. And this is an area under the curve disease. What do I mean by that? If you are unfortunate enough to be born with this condition with LDL cholesterol levels of 3, 4, 5, 600 from birth, it requires a shorter duration of exposure to very high levels to have adverse events, to promote atherosclerosis. This is why we see people in their 30s and 40s who have homozygous familial hypercholesterolemia who die prematurely. In contrast, if you're a heterozygote and your levels are 2, 3, 400, it takes longer to be exposed to a lesser degree of LDL cholesterol elevation, and for many of us, it takes even longer into our 6th, 7th, and 8th decades to accrue sufficient time with even lower LDL cholesterols, still elevated, higher than they should be, but not as high as these conditions. I will tell you that you do need to do genetic testing on individuals to be able to diagnose them with familial hypercholesterolemia. This is the Dutch Lipid Clinic from the Dutch. It's a criteria that gives points based upon definite to unlikely familial hypercholesterolemia. There's a Simon Brune also criteria, a different criteria that's out there, just so you're aware. I know you have access to all of these slides, so I'm not going to go through each criteria here, but you can certainly pull this up, and it's something that I use as a means of defining likelihood for FH. What is the support for statin therapy in familial hypercholesterolemia? And I want to point out, these are absolute, not relative risk reductions. So if you look at these Kaplan-Meier curves of cumulative event-free survival in people with familial hypercholesterolemia, if you receive a statin, those people have upwards of 10 plus years, a pretty good chance of living free of atherosclerotic cardiovascular disease. Without it, as you can show in the red dashed line that's there, those people end up having a cumulative event-free survival that drops below 40%. That is a 60% absolute, 50% absolute increased likelihood of having an atherosclerotic cardiovascular event over a 10-plus year time horizon. Here's the check again, how poor we're doing. This is cardiologists from the same registry. This is 3,124 people with familial hypercholesterolemia managed in the United States. 35% of people are either receiving no statin or no non-statin in the case of 29%, or a non-statin in 6%. 35% of these people are receiving not any statin at any intensity whatsoever. Shame on us. Again, the guidelines recommend high-intensity statin for all of these individuals, and most people with FH require multiple agents to lower their LDL cholesterol. How are we doing in those at highest risk? This is 1,200, almost 1,300 patients enrolled in the Cascade Familial Hypercholesterolemia Registry. These are heterozygotes. And look in the individuals out there. The middle column is no known coronary heart disease at the top. The right column is known coronary heart disease. Even amongst heterozygotes for familial hypercholesterolemia with established coronary heart disease, less than 50% are receiving high-intensity statin therapy, and 25% are receiving no statin whatsoever. It really is an embarrassment. And so part of me on one hand says we don't need newer medications. We do for some individuals. We just need to be treating people with therapies that we know are effective and reduce cardiovascular risk. And in the case of statins, 6 out of 7 of them are generic, with the most expensive one probably being $15 a month. What about combination therapy? This is a little bit of a busy slide. In green is the presence of just non-statin therapy. In red is combination of statin and non-statin. And if you just look on the leftward panel, you're much more likely to achieve greater magnitudes of LDL cholesterol reduction by using combination therapy. Relying on non-statin therapy alone makes it very difficult to get there. For patients who have familial hypercholesterolemia, there is a recommendation to get your LDL less than 100 as a minimum. And you can imagine if you're starting with an LDL of 500, you got your work cut out for you. What is the impact of PCSK9 inhibitors in familial hypercholesterolemia? This is another question we asked at the beginning. And as you can see there, amazingly, in this group of heterozygotes, you see a 60% reduction in LDL cholesterol in this FH population. What do our guidelines, our pathways tell us about this for FH? Well, they say consider either ezetimibe or PCSK9 inhibitors as initial non-statin therapy, and I would submit most of these patients require both. So now the last part of this is practical issues in prescribing a PCSK9 inhibitor, because I do want to be outspoken about these are the challenges that we face as clinicians day in and day out. So this is a little bit of a busy slide, but it includes the prescribing information for the 2 FDA-approved agents, alirocumab in the middle, evolocumab to the right. They're all approved, all 2 of them, as an adjunct to maximally tolerated statin therapy in those individuals in need of additional LDL cholesterol lowering amongst the FH and atherosclerotic cardiovascular disease population. Not approved for diabetes, not approved for primary prevention. These are injectable agents, either dosed monthly or every other week. They come in different either pre-filled syringes, auto-injectors, or in the case of evolocumab, it does have a microneedle infuser with a 9-minute infusion that can be given monthly. Side effects are rather small, and they reflect what you expect with being given an antibody similar to a vaccination. I always remind myself of this because my wife is always convinced that the flu vaccine gives her the flu, and I tell her it doesn't. Giving a monoclonal antibody will produce, in some cases, transient flu-like symptoms, nasopharyngitis, injection site reactions, but it does not give you the flu in that regard. Who are the patients that make the most sense to consider a PCSK9 inhibitor? I've highlighted them in green, but these are people with FH, and these are people with atherosclerotic cardiovascular disease with or without comorbidities who need additional LDL cholesterol lowering, either because their LDL is greater than 70 or they're greater than 100 in those people without atherosclerotic cardiovascular disease and with a baseline LDL greater than 190. This is a busy slide, but I want to walk you through this. Remember I told you that high-intensity statin therapy achieves on average a 50% reduction in LDL cholesterol. Not everybody achieves that effect. There are some who have a super physiologic effect and others who do not. So this is rosuvastatin, 20 milligrams a day, amongst 7,800 patients treated with this agent, looking at the magnitude of LDL cholesterol reduction. In green are people who have a greater than 60% reduction. In blue is that 40 to 60%, hovering around 50. But as you can see, there are some people who have a less than 40% reduction, and in red, some people who have no appreciable reduction and even a small increase in their LDL cholesterol. As puzzling as that sounds, when we talk about a mean treatment effect, that doesn't mean everybody's going to have the same effect. Who does it make most sense to use it in? Those people who have the least impressive effect of lowering their LDL cholesterol with statin therapy. And it does cause me to remind you all that some people read the 2013 guidelines and said, this is great news. I can put them on high-intensity statin. I never need to check lipids again. That couldn't be further than the truth. The value of rechecking lipids is A, to look to see, did they get a 50% reduction? Because if they didn't, you got to be doing something more. And even if they did achieve it, I can tell you, as I had a woman just this last week whose LDL cholesterol was 54, 52, 48, 61. Over time, I checked her annually. Her last one was 112. Clearly, it is a clear signal to me she's not taking her therapy. Now, maybe she went on a cruise and ran out of her medication and forgot it for 10 days. Maybe something else came up. But it also is an opportunity to be able to reflect on likelihood of adherence overall. So a balancing act with PCSK9 inhibitors is really about direct cost versus cardiovascular benefit. I do want to highlight this, that access to non-statin therapy in patients at high risk is hard. On the leftward side are people with familial hypercholesterolemia, and on the rightward side are atherosclerotic cardiovascular disease, looking at claims data. And in the boxed areas I can show you, in the far left corner, 63% of people initiated on a prescription for a PCSK9 inhibitor for familial hypercholesterolemia had it denied by a payer. On the right-hand side in the box, amongst people with atherosclerotic cardiovascular disease, 58% had it denied. So you may say PCSK9 inhibitors, cost is a big issue. I might be able to reconcile this. Ezetimibe is generic, and when this study was conducted, it has been generic. 9% of people with FH prescriptions for ezetimibe were rejected, and 8% with atherosclerotic cardiovascular disease. And I looked on one of the websites recently, and in Portland, Oregon, I can get generic ezetimibe for between $18 and $24. Not as inexpensive as a $4 or $10 prescription, but a much lower cost than typically our branded agents. So what is the cost of potentially implementing a PCSK9 inhibitor? This is modeling data published this year in Circulation just a few months ago. If every patient enrolled in Fourier was started on a PCSK9 inhibitor based on the entry criteria, it would cost the United States about $2 billion for this medication, class of medications alone. If we titrated every person on moderate intensity statin therapy to high intensity statin therapy and started ezetimibe for those not on ezetimibe, it would be on the order of $0.2 billion with substantial event reduction. If we then started evolocumab in those people who still had an LDL cholesterol greater than 70, in spite of that, it would bring the cost up to just about $1 billion. So we're not implying that everyone and their mother warrants PCSK9 inhibitors, but we really need to be thoughtful about aggressively getting people's LDL cholesterol down. And as I can point to, we have upwards of 30 to 35% of our highest risk individuals receiving no statin therapy at all, and shame on us overall. Some people have recommended applying a quantitative approach to adding non-statin therapy. So the reality of this is, when you start talking about cost effectiveness, the best surrogate for that, if you're going to look at a surrogate, is number needed to treat. And the number needed to treat to benefit from a PCSK9 inhibitor or ezetimibe is highest in those people who are highest risk and furthest away from where we want their LDL cholesterol to be. And as you can see, this publication by Jennifer Robinson last year highlighted people who are in this very high-risk group, where they have a greater than or equal to 30% chance over 10 years of having a fatal or non-fatal event. They then broke it down into a high-risk group and then a moderate-risk group overall. And if you think this is all sort of theory and nobody's actually doing this, the American Association of Clinical Endocrinologists this year for diabetics with atherosclerotic cardiovascular disease is now recommending an LDL less than 55. And the 2018 guidelines, which aren't out because it's not 2018, probably will come out late next year, I have nothing to do with, but you could begin to start thinking lowest LDL cholesterol that can be reasonably achieved, both from a safety, tolerability, and cost standpoint overall. So lower is in fact better. And this is a busy slide, but it can show you that the number needed to treat depends upon the baseline risk of the individual you're treating. Higher risk, more benefit, more cost effective. Further away from goal, more cost effective overall. I'd be remiss if I didn't share this. And this is a great example of talking about, if anybody ever comes to you and talks about the donut hole in Medicare Part D and how it works, this is an interesting schematic. So for commercial pay patients, the PCSK9 inhibitors can be subsidized in other ways. But for our government payers, and let's just say Part D, the average out-of-pocket cost for the PCSK9 inhibitors today is around $330 a month. Really expensive. However, you can see the breakdown of this is first month prescription, they haven't met the deductible phase where the cost may be $600. They're then in the initial coverage phase where the price drops. Then they're in that coverage gap period, and that coverage gap is AKA the donut hole. But most people are unaware because we've never gotten to this point, but now we're beginning to. There is catastrophic coverage. When you have your annual spend, out-of-pocket spend, exceeding $4,850, the amount that you will be responsible to is only 5% for the remainder of the year. And this becomes a hard thing to talk through, but you have to understand the economics of this. And I'm not naive to that. I don't want to seem like I'm on a soapbox here, because I have these same conversations with patients and try and figure out unique ways. Our foundation at our hospital is subsidizing some of the costs for this overall. We're looking for creative ways to help people get their medications paid for. So finally, I'd be remiss if I didn't talk about this, the patient-centered approach to lipid lowering. This is a reality check, but it's all too true. And everybody I talk to says that's somebody else's patients, it's not my patients. It doesn't matter what chronic disease, we could be talking about COPD or hypertension or hypercholesterolemia or atrial fibrillation. There's an attrition, there is a decrease in compliance, adherence to risk-reducing interventions over time. It's a busy slide, but it took almost 30,000 people after a heart attack and looked at their statin utilization, what it looked like over time. Out to a period of 24 months, if you look at the one group that is accounting most for the decrement in statin use, it is that group that's in the middle, the third one down, statin use with low adherence. So they're prescribed a statin, but they're just not being adherent to actually taking it overall. And if this is with a medication, and I now have in my group of patients that I manage, about 35% of my patients on statin therapy get it with $0 copay. They have no copay whatsoever. The remaining spend between $4 and $10 a month for those prescriptions. Cost isn't the biggest barrier. Don't get me wrong, $8 a month is $8 a month not in your pocket, but it is arguably one of the most cost-effective interventions out there. I borrowed some slides from all of you. So what are the predictors and dimensions of non-adherence? These are of no surprise to those of you in this audience. It speaks to the panoply of things that we all struggle with. So, okay, you eliminate cost. Well, it may be related to literacy or understanding, or psychiatric disease where we know compliance with therapies is overwhelmed often, and you can see a 30% reduction with adherence just by the presence of that alone. There are multiple issues at play overall, and solving one, you almost feel like your arms are tied. It's one of those things where if you pull a little inward on one arm, it's pulling your arm on the other side because something's got to give, and it really makes, for all of us, a challenge in trying to get people to be compliant with these therapies. You all may be familiar with this. I love it. Simple strategies that are aimed at improving adherence. Simplify the regimen where possible. Daily versus twice, or God forbid, 3-time daily regimens. And I'm as guilty as anybody, but really trying to simplify it. Imparting impactful knowledge of the people, having them understand why they're taking it. And it always frustrates me when I see, as a consultant most commonly, people come to me, I say, well, why are you taking this? They're like, my doctor told me to. And I said, okay, I get that, but why are you taking it? And they don't understand even what the medication is intended to do. Modify the patient's beliefs in human behavior. This is easier said than done. Provide communication. Engage them in a trustful relationship. Leave the bias and evaluate adherence. And again, there are a lot of docs who I think willfully tilt a blind eye to just believing the patients are taking their medications and thinking somehow I've discovered the secret sauce that nobody else has. But the secret is those people have compliance and adherence issues over time. So I just want to show you this example because it's a cool example if you could eliminate one powerful thing that we talk about. It's the MI-free, with an extra E on it, study or trial. This was published in New England Journal of Medicine 6 years ago. It took almost 6,000 people after a heart attack and randomized to full prescription coverage, $0 copay, for statins, beta blockers, ACE inhibitors, or angiotensin receptor blockers for a median of 1 year, compared to usual coverage. And that usual coverage at this time may have well been generic out-of-pocket costs, but it was eliminating completely. There's no excuse. These people are getting all their drugs for free. As you can see, there was a statistically significant increase in statin adherence, but only of a magnitude for all patients of going from 49% to 55%. So so even eliminating cost altogether doesn't ramp up dramatically adherence to these therapies overall. And when you look at the rate of adverse cardiovascular events, it didn't make a dent. Maybe because the magnitude of absolute increased adherence was rather small overall. So while on the one hand it's always cost, and I would argue it is a very reasonable thing to address, when you eliminate costs with a well-tolerated, largely medication, it doesn't dramatically move the needle. So I was fortunate to be involved with this writing group in this paper, that came out now about 2 years ago. And I think the bottom line is it begins with a clinician-patient risk discussion. Even in primary prevention, when somebody has a risk threshold of 8.6%, the answer is not statin. Now, the calculator may say that this person is recommended to be on a statin, but it really involves an engaged discussion. And certainly for those that are even higher risk that are secondary prevention, they've had a heart attack, they've had a stroke, or they're familial hypercholesterolemia patients, it's a matter of talking about lifestyle. It's setting up and engaging people in an effective way so that they understand why they're being treated with the medication, what the potential risks are. And I dare say today, none of us in this room are reimbursed to spend a lot of time talking about prevention and wellness. And so I'm going to submit that the 30% of cardiologists managing people with atherosclerotic cardiovascular disease on no statins are not because 1 out of 3 cardiologists don't know statins are beneficial. It's the patient comes in and says, Aunt Marge was on a statin. She didn't tolerate it, so I'm not going to take it. And they're like, okay, I'm busy. That's going to take a long time to have a conversation. And I hate to call it out, but I'm not paid to have this conversation. You don't want to take it? You don't want to take it? I'm going to tell you it's the right thing to do. But we need to figure out a better way to be able to do this overall. And who are the people that maybe are better engaged at being able to initiate that conversation or coordinate their care just on lipid management going forward? I will also say that decision aids can be useful. This happens to be the one from the Mayo Clinic. But sometimes people are very visual, and an infographic or saying, okay, I'm like this person, how many smiley faces of people are going to benefit, how many people might be harmed, and how many people may not derive as much benefit overall. And it allows you to be able to model this for a patient so they can get an idea of what is the magnitude of benefit. 15% relative risk reduction may mean nothing to a patient. It may not mean a lot to a lot of clinicians, but these types of tools can be powerful in engaging other clinicians, members of the care team, and patients as well. I do want to acknowledge the importance of statin intolerance. This was a study just published in the last 2 months looking at patients who were statin intolerant versus those receiving high statin adherence. And people that were statin intolerant had higher rates of coronary heart disease, recurrent myocardial infarction. This is not a benign condition. And so, are there tools to aid me in addressing these things? We know it's going to take time, but if it's going to take time, make it easier for me to spend that time. And so, I will say I'm fortunate enough to be very involved with the American College of Cardiology. We built out a whole bunch of apps. These are all free for you on Google Play or iTunes, but they're free apps to be able to give you, developed by one of our professional societies, to give you resources to help with this. So in the case of statin intolerance, underneath an app called the LDL Manager app, there is a statin intolerance app built in it. So if a patient has muscle aches, how should I handle this? What should I tell the patient? What should I do myself? How do I re-challenge them? Do I switch to a different statin? These are things that aren't necessarily readily obvious to all individuals. Leverage those tools to help you out overall. And this is another slide I borrowed from all of you. This is a team sport. I would say all chronic disease management is a team sport and requires having a coordinated team. We're exploring at our own institution whether clinical pharmacists or an advanced practice provider, nurse practitioner, physician assistant run lipid clinic, somebody who's freely engaged about doing this work, where it actually makes sense to say, you know what? Unfortunately, we don't have sufficient time today. It sounds weird saying that, to go into a lot of these details. But the good news is I have somebody literally right next door who can go over this with you. Or we need to find a way to be able to answer all of your questions so you really are engaged and understand the importance of why you're taking this therapy, which is almost certainly likely to result in improved adherence overall. This also means extending beyond just your own offices. How do we coordinate endocrinologists? with cardiologists, with lipid specialists, with primary care providers. And I don't want to begin to say I have all the answers. I'm in a near integrated delivery network where we have over 23,000 physicians that are on a single electronic medical record. Pretty cool, and I would dare say we haven't figured out how to solve all problems in care coordination. It still is a struggle. Who owns lipid management? Okay, if you own lipids, are you owning hypertension as well? Hypertension guidelines come out in less than 2 weeks. The new guidelines come out. Who's going to be owning that implementation? This is a really challenging issue, and I applaud all of you in trying to figure out creative ways to solve this overall. So just in the final minutes, statins are the most effective traditional LDL cholesterol lowering therapy and should be used at the maximally tolerated intensity in those at highest risk. I don't want to ignore primary prevention, but if we did nothing other than this group, I'd be ecstatic today overall. The currently approved PCSK9 inhibitors, alirocumab and evolocumab, significantly lower LDL cholesterol at the tune of 60%. The PCSK9 inhibitor evolocumab in the Fourier trial significantly did reduce the rate of adverse cardiovascular events without any signal of safety concern, even to a mean LDL cholesterol of 30. And it validates no longer a hypothesis, but I think what would be now our understanding that lower LDL cholesterol levels are associated with lower risk overall. For those in whom a PCSK9 inhibitor is approved, there may be significant out-of-pocket costs, and you need to be aware of that, and how do you work through those overall? Quantitative assessments may help you understand who am I most likely to derive, even in that high-risk group, the greatest benefit, where I'm going to push harder to figure out ways to help with cost and coverage. Adherence to lipid-lowering therapy decreases significantly over time, and there are a number of strategies that can improve adherence, but it begins with that clinician-patient risk discussion. And decision aids, apps, web-based tools can all be effective tools to help complement your engagement and discussion. So I know we have roughly till 2:05. We have a few minutes for questions. I see one up here. I'm happy to entertain questions for a few minutes. I want to be respectful of you guys getting the next session. But question.
Is there a concept that the serum cholesterol doesn't correlate with tissue level cholesterols?
Yeah, so the great question, it was a little muted when you first asked it. Great question is getting your head around the notion of having LDL cholesterol levels, even in the single digits, the 20s, the 30s in that regard. So when we measure cholesterol, we're measuring the bloodstream as opposed to a tissue level of cholesterol. It is true, going back to data from the 70s and 80s, there was speculation that low total cholesterol was associated with an increased risk of intracerebral hemorrhage. That has not been replicated in any of the contemporary trials over the last 10 years. Now with trials getting LDLs in half of 17,000 people to an average of 30. So I think the notion will be there is no floor today that exists. I want to be clear, I'm not adding on Nonstatin therapy in those individuals, but I'm also not pulling back in those people. And I want to be clear, I'm looking at tolerability. If somebody doesn't tolerate that statin, and I can't find a statin regimen that will get them on a level to even get them close to that level, I will explore Nonstatin if their LDL in particular is above 70 and certainly above 100. But I'm also not willing to just pull back just because their LDL is 27 or 38 because I put them on a high-intensity statin. And I think that's a lesson learned. We didn't know the answer until we had a trial like this. It wasn't exactly answering that question, but I think the data extrapolated by Fourier helps to validate that there isn't a safety concern right now with such aggressive LDL cholesterol lowering. Great question.
I don't see anyone over there.
Sure.
Can I ask a secondary question? There's murmurs in the literature about statins flipping pre-diabetics into true diabetes, and also statins associated with dementia. Can you speak to both of those?
So great question, and these are some of the myths that go out. I'm leading a national effort for the American College of Cardiology to debunk some of these myths. Let me just start by saying a pooled analysis, the dementia question with regard to statins is actually in a trial of over 80,000, pooled analysis of over 80,000 people, statins actually significantly decrease the risk of dementia, primarily by reducing multi-infarct or vascular dementia. We have no reason to believe that it's reducing Alzheimer's dementia prevalence at all. But it doesn't increase the risk of neurocognitive effects from what we can tell in a pooled meta-analysis. And with the PCSK9 inhibitors, a formal trial dedicated to that showed no signal of that at all. Diabetes, the greatest data comes from Jupiter. There is a small statistically increased risk of developing diabetes with the use of statins, most notably driven by data from the Jupiter trial. To be clear, and this is not surprising to most of you, is a lot of the people in primary prevention we treat They have metabolic syndrome, truncal obesity, high blood pressure, low HDL cholesterol, high triglycerides, impaired fasting glucose. They're on a path or a trajectory to diabetes. The analysis that's been done, and this is modeling data, suggests that the time in which the time in which statins accelerate the development of diabetes is on the order of about 30 to 60 days. So you're just shifting people to develop that diagnosis that much sooner, and then they warrant statin therapy because of its attendant benefits. Don't get me wrong, I'm very upfront with patients to say this is one of the things where there's a statistically higher rate, but it is also something that I feel overwhelms your benefit. And to be clear, 70+% of people with diabetes die from macrovascular events. So this is the calculus, but I think you have to be transparent with patients. So we have to be truthful in debunking some myths and also acknowledging other things that are not a myth. Great question. So I want to respect everybody here. I'm happy to answer a couple more questions, but thank you so much for the opportunity. Have a great afternoon and a great conference.